of the Adult Heart Disease Center at the Mount Sinai Hospital in New York, and who will be talking today about a very exciting topic, which is neurocognition in adult heart disease, paradigm or perception. So Ali, thank you for joining us, and the floor is yours.
Thank you so much, Rafa. Thank you, Irvin. Thank you, everybody, for having me. So this is an interesting topic for me also, and I'll tell you why I'm calling it paradigm or perception. Let me make sure the slides are all there. So here are my disclosures, and I'll start right off the bat. And some of you know me. I'm not a psychologist. I'm not a neuropsychologist. I'm not a psychiatrist, not a neurologist, and not a neuroradiologist. So why am I saying this is because what I am is an ACHD clinician, and I just happen to be curious about neurocognitive functioning in adults with congenital heart disease. And this happened maybe a couple of years ago when several of us through the ARC network were thinking about research ideas and projects, and then it got us thinking. So let me start with just a case, and this is not something that's substantially different from what you probably see in your clinics. This is just a 23-year-old with a G-transposition, comes in, has a switch operation many years ago, no other operations, has good function, echo looks good, no significant past history, no family history, is on no medicines, doesn't do any recreational stuff, gets a decent student, went to a local college, but says he had made significant efforts to get through college, then started grad school, and now comes in for a visit, but he says, you know what, I can't do this anymore. I just don't think I can do this. And then the question comes as well, if he's doing well from a heart standpoint, doesn't have any medical conditions, he is not doing any drugs, why is he struggling? Why is he struggling through this process? So the question comes, why? Why does this happen? I see this often, again, as a clinician, we see this in our clinics, is these young patients are coming in and they've done very well over many years, but we feel this angst. We feel, or at least I feel this angst from them, that there is a perception that they're not able to get through the hurdles that should have been easier to get through. So the question then comes is, why is this happening? Is this coming from the heart? Is this a heart problem? Or is it coming from the brain? Or is this a brain problem? So where lies the issue? And it sort of makes one think. Or is there a heart-brain connection? Is there a connection that we as clinicians, as ACHD physicians, haven't put our finger on? And I'll get into the data in just a second, but the question then comes is this a heart-brain connection? And what this means then is, well, what is going on in the brain? What's going on in the brain? Well, when you look at the brain, and again, as I said, I'm not a neurologist by any means, and this process of, as I've read about this and started thinking about it, it goes back to the functions of the brain. When you look at the brain, you have all these different parts of the brain, the motor cortex, the sensory, the parietal lobe, the occipital, but it's really the frontal lobe, and we'll keep coming back to this in a second, that's where we have the center for thought processes, executive functioning, thinking. Can we plan, organize? Can we problem solve? Our emotions, the behavioral control, personality effects, so impulse, things that we as maybe ACHD docs don't often think about, but that's really where the crux of what we're going to talk about lies. Which then comes to, well, what is this? What are these words? What is cognition? What is neurocognition? What is neurocognitive dysfunction? Are these all the same colors of the same fruit? Are they all similar, or is there some difference? And as I said, as I've gone through this, let me take you some definitions that I think it makes sense to me as I think through this process. Well, what is cognition? Well, cognition is the mental action or process of acquiring knowledge and understanding through thought, experience, and the senses. So you're taking a process and you're putting it through your own experiences, your senses, and coming to a conclusion. But what this means is there are aspects of intellect, and other processes like attention, the formation of knowledge. So it's not so much the knowledge, but it's really the formation. How do you get to the process, the concept of memory or working memory? How do you take memory and then make it into something that's workable? Judgment, evaluation, reasoning, computation, decision making. How do you comprehend the words that are either on paper or words that are being spoken to you? How do you put it all together? And how does this then manifest itself in life? So that's one way to look at cognition. Well, what about neurocognitive function? You hear this word, and we've heard this word many times now. What does this mean? What this means is that there's cognitive functions that are probably linked to the function of areas in the brain, neural pathways or cortical networks. Maybe there is a molecular level where this is happening, so there's a connection between the neural part and the cognitive parts, the neurocognitive functioning, and that's sort of where this definition comes from. Well, what about dysfunction then? What does this mean, neurocognitive dysfunction? And it took me a while to sort of, and as I said, I'm not a neuropsychologist by any means, but as I think through it, what it means, I think, is that it's a reduction or an impairment of the cognitive function when there's physical changes that are happening or might have happened to the brain, either from an illness, maybe there's a mental illness, there was drug use, there was direct injury, but something that happened that causes that connection to be impaired. And that's sort of the process, or the thought process of neurocognitive dysfunction. And I'll talk a little bit more about this, as I said. So what does this mean? So what is neurocognition, and how, is this an abstract concept? Is this a perception? Is it? And it isn't, and we'll get to that in a second. Or is it something concrete? And I say this because us as clinical ACHD docs or clinicians, we see patients, we like to see things concrete. You know, ventricular function's down, EF is down, we can see the ventricle, we can see the valve, we can see the fontan, we can put a stent in. So this concrete, but where does this lie? And what this brings us to is this paradigm, this process of thoughts that we perhaps haven't paid a lot of attention to. And this is these are the thoughts of, as I said, you know, feelings and concepts and language formation, attention. How do you take attention and make it into something that's workable? Memory. You know, how do you create decision-making processes? So somewhere along the lines, this is where we're gonna go forward with. Now, which then brings us to, well, if there is cognition and neurocognition, then what are the domains? And let me just take about 10-15 seconds on the slide just to explain what this means. And there are multiple domains, and I'll show you another slide in a second why this is important, and this is a learning process for many of us, is that when you look at neurocognitive domains, there is language, and within language there are there's granularity within the concept of language itself. It's object naming, word finding. How do you take language and understand it and process it? Memory, it's free recall, long-term memory, implicit learning. There's social cognition. There's attention, and within attention there is granularity, selective attention, divided attention. How do you processing speed? And then there's perceptual and motor functioning, which is again a coordination between what you perceive and how you react from a motor standpoint. But this is where we're going to spend a little bit of time, is executive functioning, which is really the sort of the hierarchical, top-notch cognitive domain in my mind, which is how do you take everything and plan, make a decision, put a working memory together? How do you take a thought and then quickly process it, say, well, I can do this, cannot do this, the concept of flexibility or inhibition, and we'll get into this into just a second. So as I said, there's a hierarchy, even within neurocognition. So when you start at the bottom, there is medical history, and there is brain function and attention, and within memory itself, there's granularity. But really, it comes down to executive functioning, and what does that mean, and how does it impact our patients when we see them? So let's go back to this slide for a second. And as I said, there is a heart-brain connection, but we will get into the sort of the bird's eye view of the connection between congenital heart disease and within that adult congenital heart disease and the brain. And so that's where we're going to go. So let's take a little bit of a step back and say, well, yes, we are talking about adult congenital heart disease, but if you go back and take a look at children with congenital heart disease, has this been described? And to me, again, being so as some of you know, I wear two hats. I have an adult congenital and a pediatric cardiology hat, and within that there's adult cardiology. But if I just wear my pediatric cardiology hat on for a second, is that there is tremendous amount of data that has come from many, maybe about 2 decades now, and there have been consensus statements about neurodevelopment in children with congenital heart disease. And what's fascinating is I went back and took a look over the last 20 years as I was getting data together, and there are almost 400 publications on children or with congenital heart disease and the concept of neurodevelopment, and that gets into fetal and infant and children. There's some tremendous names like Jane Newberger and Bradley Marino and Gil Vernowski and Dr. Gaynor in Philadelphia. They've done a tremendous amount of work over the last 2 decades, maybe longer. And they've talked about risk factors and outcomes and predictors in children. So we'll keep that concept in mind for a second, and I'll come back to this. But let's look at neurocognition in adult cardiovascular disease. What about just adult cardiovascular disease? So I'll put my adult cardiology hat on for a second and just look at it from an adult standpoint. Well, when you go back 20 years now and take a look at in adult cardiology, more than 300 publications of various forms of neurocognition or cognition in adult cardiology, but it gets granular with adult heart failure or coronary disease, stroke, dementia, so adult onset. So we're talking about the 60s and the 70s and the 80s, and certainly in the, maybe a little bit in the younger cohorts too. But when it comes to adult congenital heart disease, it's very, very interesting. You go back 20 years, and really there are about 34 PubMed publications that are out there. And maybe give or take, there might be here and then there might be more, but that's really what they are. But when you get granular in there, there are really 13 studies that carry some weight in the sense that they were just dedicated to adult congenital heart disease. They were not reviews. They were not data that was looked at and then and as I said, put into a summary format. There are 8 clinical studies that are within 18 to 30 years of age. So let's look at that age group, and I'll walk you through some of this, is that you're still looking at a younger age cohort. And within that, there are only 5 clinical studies that sort of touch on adult congenital patients who are in their 40s. So again, small cohort, small numbers, very few studies, even though in congenital heart disease in children and there's been a tremendous amount of data. So what does this mean? Well, what this means in my mind is, are we looking at a paradigm that goes from babies or fetuses through the transition years and then to adulthood and then older age group? And this is a great paper, and I'll walk you just a little bit through it. This is from Arian Morelli's group. This is about a year ago. It's a very nice review. And what they talk about is, well, when we look at neurocognitive dysfunction, maybe we should be looking at the fetus with congenital heart disease. So when we look at the fetus, and they go through these fetuses have cyanosis or hypoxia or genetic syndromes, and they get, when they're born, they're going through multiple surgeries, and they can have post-operative complications. They get a little bit older, they have multiple admissions, so they're now in their younger age groups. They have now manifesting learning difficulties. They're going through transition years, early adulthood. Now you're looking at psychiatric conditions, and now you're running into some of the adult issues like arrhythmias and strokes. And when you get older, now you're getting the effects of the aging brain on. So is this a continuum that starts early and then goes on? And our world of adult congenital heart disease is probably somewhere here. And as I said, the data hasn't even come to this age cohort. We're still here somewhere, but there is certainly data out there that this is something that we need to think about. So again, looking at this review paper, I thought this slide was very well put together, because if you look at the top, this is where the infant and the fetuses start neurodevelopment. And that starts as a fetus, as a child. And then congenital heart disease stays with you. That's a process that you're born with. That's what you'll have. But you get older, you have acquired cardiovascular conditions. And then the cerebrovascular lesion burden, like strokes, and that sort of manifests itself as you get older. So certainly this is a lifespan problem that we need to look at. And what I liked about this slide was because it puts it all in a very nice summary format, is that yes, there is congenital heart disease, but within the fetus and the infant and the adult, at each age group, there are different exposures to injuries. So as a child with cyanosis, you're looking at, as I said, hypoxia. You get further along, you have cardiopulmonary bypass runs. There's a complexity, and you get into adulthood where we come in as ACHD physicians. We're looking at all adult onset conditions, and these are evolving risk factors, and I'll get into that in just a second. But look at the brain. The brain itself has that expression of injury. You can have problems when you're a child, as an infant, and a child, and as an adult. So clearly, this is something that's across the board, and this then leads to the spectrum of neurocognitive decline. Scott Cohen put again a review paper together, and Scott and I'll talk about our work together in just towards the end of this talk. Is that and there's lots of risk factors for children with congenital heart disease, and I won't get into this because there's a ton of data for this. That multiple runs, cardiopulmonary runs, there are hospitalizations, prematurity, genetic syndromes, and again I won't get granular with this, but these are risk factors of the child. And you move into the same child now becomes an adult, and now you've moved into the adult world with heart failure and coronary artery disease. And so are there risk factors changing? Yes, there are. And this is something that we as ACHD physicians need to recognize as what this means for our patients. I'll talk about that. But this is an important concept, just so I can explain this, is that what I've learned over the last few years as I've spoken, as I've talked to colleagues, is that we're ACHD physicians, but I have found that this field is really something that is coming from neuropsychologists, from specialists who have done this as a career. And I have found that their interpretation of these tests, and I'll talk a little bit about this, is tremendously important, because we think of tests as an echo done in 20 minutes, 30 minutes, we put a report in. These are sophisticated, validated tests looking at different domains of cognition. And the role of neuropsychologists in this field is tremendously important, and I cannot drive this point home how important the testing is and what this testing means, and the role of neuropsychologists. So let me come back to executive functioning for a second, and why am I talking about this? What this means is this collection of control processes that rely on instinct. So what that means is how quickly can you put your processes together and make a thoughtful decision. It is a manifestation of a higher level of functioning, and how you keep things organized in your mind, and how do you then process it into function. The three concepts is working memory, how you put memory in your mind together. You take verbal and visuospatial clues and then plan, and you take that process and make it into something tangible. And so working memory is tremendously important. There's inhibitory control, how we all go through this, each one of us, how we think of things. We have this concept of self-control, we have selective attention, how we override impulses and do what's appropriate or do what's inappropriate, because we're unable to process this together. So the concept of inhibitory control. And then cognitive flexibility, where you're changing perspectives, where you're getting clues, you're getting visuospatial clues, and how you put it all together and then reframe your thoughts and ideas into something that's going to become tangible. So executive function is tremendously important. And what this means is that this, to the different levels of working memory and inhibitory control and cognitive flexibility, you reach problem solving and planning. Can you take abstract relationships, assess the risks, and think multiple steps ahead? So you're not just taking one step, but you're planning ahead and saying, well, how do I take the next steps forward? So let's go back to the brain then. So when we've talked about all this, I'm going to take you back to the brain, and I'm going to take you back to the prefrontal cortex. What this does is that you decide, based on the impulses and the thoughts that you have, what's good from bad, what's socially acceptable, what isn't. How do you decide Coke from Pepsi, or Pepsi from Coke, or from diet from non-diet? Or you take your thoughts into action and inaction, and then make decisions, and again, not just one step, but multiple steps forward. So again, the brain plays a tremendous role. And in that is the prefrontal cortex, where this is certainly the frontal part of the brain, but what we know is that there is development that's happening in the brain. And what's fascinating is that this continues to develop till about the age of 25, and there could be varying responses with experiences and stimuli and challenges. And I'll talk a little bit about the brain itself and how there's some emerging data, how the brain changes with congenital heart disease. So again, I won't get into this. There's a ton of data for children with neurodevelopment and in children. And really the point I'm trying to make here is that when you look at the data, the prevalence of neurodevelopment, or let's say neurocognitive dysfunction in children, is significant. And when you put everything together, that arrhythmias and operations, endocarditis, and you look at all the kids out there, so not adults, all the kids out there with congenital heart disease, the chances are that they probably have higher levels or more prevalent, or the neurocognitive or neurodevelopmental concerns are more prevalent than all the sort of congenital cardiovascular things that we think about, like stents and arrhythmias and heart failure. So clearly it is prevalent, and there are many factors and variables that we can look at. But what this tells us then is that as ACHD docs, this is what we do. We look at patients with lung problems and pulmonary hypertension, vasodilators and Fontans and liver and immunology and hepatology. But are we adding another paradigm to this now, where neurocognitive functioning or dysfunctioning in adults with congenital heart disease is something that we really need to think about? And that's where we're going to go. So what this means ahead is this a paradigm ahead? And this is where we're going to go. So let's talk data for a second. So what's the data out there? I'm going to spend the next 5 or 7 minutes talking about that. So I'm going to take you over these last 15 or 20 years. What I want you to pay attention to is the cohorts. Look at these cohorts, 50 patients. This study was looking at a mean age of 32 in tetralogy of Fallot patients. They did neurocognitive testing, they did a psychological assessment, and I won't get into the granularity of which test. It is beyond the scope of this lecture, and we certainly need neuropsychologists involved in that concept. But what this tells us is that in this study, what they found that patients with tetralogy of Fallot had average quality of life, but what they really found was the major deficit was in executive functioning, in their ability to problem solve and planning strategies. And what you look here is different metrics of cognition. And this is the Tower of London. So this is Rafa. This is a call out for you, Tower of London, right here. And what this tells you is that there is neurocognitive dysfunction. I won't get into the granularity of that, but again, executive functioning was a problem. If you take this next study in 2015, so roughly about 8 or 10 years later, again, tetralogy of Fallot, looking at teenagers, look at the cohort, about 80 patients. And again, what they found here was that when they tested them for neurocognition, mostly attention deficits and executive functioning. And again, as I said, executive functioning is that hierarchical order where that's really where you're going to make decisions. And when you do this, again, we look at the right side, it's very, very sophisticated testing, but that's the crux that you're finding, is that they certainly have problems. This is data from Don Ilardi, and what they showed was, again, a small cohort, but what they looked now was moderate to severe congenital heart disease, taking both cyanotic and acyanotic patients. And what they found was, again, that even though these patients had similar educational levels, executive functioning was worse. And what they also found was the more the severe the congenital heart disease, the worse the ejection fraction. So it sort of brings that link between heart and brain sort of starts coming in now. And what they showed here was, if you look down here, they broke it down into broad categories: single ventricle cyanotic, perhaps the most complex, 2 ventricle cyanotic, and 2 ventricle acyanotic. And here what they're saying is that when you look at this, these are patients who had neurocognitive dysfunction. When you look across the board, here's neurocognitive dysfunction. So the patients who were more complex and more complexity from congenital heart disease had the highest level of neurocognitive dysfunction, versus when you compare 2 ventricle cyanotic versus 2 ventricle acyanotic. So the worse the congenital heart disease, worse the neurocognition that they found. And again, this was worse executive functioning. There's a higher likelihood of disability, higher likelihood of unemployment. We'll get to that towards the end of the talk as to why that is important to understand. This is data again. It was showing, looking at moderate to severe congenital heart disease, a small study, cohort of 48, and they look at using this test called the CNS vital signs. And if you look here, the black bars are moderate congenital heart disease. The white graph, the white bars are severe, and across each index that they measured, so verbal memory, visual memory processing, the severe congenital heart disease patients did worse when they compared to moderate. So across every domain, severe congenital heart disease patients were doing worse on neurocognitive outcomes. So again, every domain that they looked at. What they also showed in this study was the number of surgeries that these adult congenital patients have. So the further that you get along, the worse the executive functioning is. So when they're one surgery versus 4 or 5 surgeries, they have worse executive functioning down the road. So again, this is something that we need to think about. This is data looking at a younger cohort, again, of repair tetralogy and transposition, a smaller study. This came from Vanderbilt, just 18 patients, and they looked at IQ. And if you look here, these are cases. So these are cases, and then these, the black graphs are cases, and the checkered graphs, bars are the controls. And what you look here is that this is average IQ. So when you look down here, when you look at the controls, you would think this graph is a little misleading in the sense that when you look here, they're actually doing worse. They're lower IQ when it comes to patients with tetralogy and transposition. But when you get into the higher IQ, they're actually doing worse. So across the board, their IQ levels were certainly on the lower side. This is data from New York, from Presbyterian. Again, I apologize for the busy slide, but look at the cohort, 67 patients looking at transposition, primarily at arterial switches. And what they again found was IQ was lower in patients with transposition. The cognitive difficulties were higher. But here, just to show you what they did, and just to, if you look down here, this is transposition patients, these are controls, and they broke down cognitive impairments into the cognitive dysfunction into impairments and difficulties. So when you are in this dark brown or red, if you want to call it, this is where you have impairments. This is difficulties, and this is expected, and this is what's expected in the general population. But when you look across each board, these are significant differences in impairments and in difficulties. So the point being that you can be significantly impaired and not just have difficulties. And they sort of got granular between impairment and difficulty. So this is an important, again, concept to grasp. Same group looking at transposition, and they sort of broke it down a little bit more. And just to show this again is that they took down many different domains. And when you look at these patients, again, if you look here, these are moderate to severe deficits, and these are difficulties. So same concept. When you broke it down into every single neurocognitive domain, patients certainly had more neurocognitive impairments. They were very significantly impaired and not just having difficulties. So again, the concept comes in is that across the board, when you sort of break this down and get granular, there are difficulties on many different neurocognitive domains. So this is data, oops, sorry, let me go back here. This is data that recently came out about a year ago from UK. I found this very interesting only because look at that number. It's from the UK Biobank. I'd love to get Rafa Stan, maybe he can explain this to me down the road, is look at that cohort. It's 1,000 patients and 987 controls. But when you look through the paper, they only had about 90 complex patients, and most of them were mild complexity, and they were really all shunt lesions when you look at the data. And again, don't worry about these numbers. Let me just tell you what they did. They took multiple different testing domains. And what they basically found was that there's reduced visual attention, cognitive flexibility, which again is a manifestation of executive functioning, and processing speed in even a large cohort, even though these are predominantly mild complexity and essentially shunt lesions. And this data just recently came out just a few days ago. I thought this was a very sophisticated study done very nicely in Australia and New Zealand from the Fontan registry. And what they looked at, again, and not a huge cohort, it's 107 patients. And what they did was they took their controls as transpositions, 50 transpositions and 50 normals. And then they looked at the neurocognitive testing. Oops. across the Fontanes, with the controls being transpositions and normal patients. But what they found was that there was again neurocognitive dysfunction, either psychomotor, attention, visual learning. But look at the age at the Fontaine, time from the Fontaine, and then total inpatient days when they were children. So again, clearly there is a problem that we're seeing in patients with complex congenital heart disease. And when they got granular with this, and they broke it down into different domains, be it psychomotor, attention, visual learning, paired association, the red is the Fontaine. There was a problem. There were higher impairment across all the different domains when it comes to neurocognition. What you also then see is the controls transposition, and these are your healthy controls. So you can see that compared to the healthy controls, even the transposition patients were doing worse. But certainly the Fontaines were at the highest disadvantage. So again, a sort of very sophisticated, nicely done study. But this is really what which catches my eye is the brain. And what they did was they looked at brain volumes. This paper just came out a couple of days ago in circulation, and they looked at total brain volume, intracranial brain volume. The Fontaines are in the blue, the reds are the controls. And if you look across each domain, the Fontaines had lower brain parameters, be it volume, and then broke it down even into subcortical and cerebellar volume. So again, what they were showing is that there's certainly a link with the size of the brain. And as I said, as I started this talk, that is there a heart-brain connection? Clearly, this has been shown in children before. This is not the first time, but this is probably one of the more sophisticated first studies with looking at brain volumes in adults. So I take you back to this patient that we started with. Where are we? This person's done well, but he struggled. He's struggled through his educational course, and now he doesn't want to go forward anymore because and when you talk to him, he said, "No, I can't do it. It's too difficult for me," even though he overall looks good. So is this a continuum? And we've sort of touched upon this. And why am I saying this is because in our minds, I think this is not something that is fixed. This concept of neurocognition is a changing concept. And I'll take you to this, which is a non-congenital heart disease data. I found this very fascinating. Certainly Australia and New Zealand seems to be doing it very well. This is data over many decades. If you look here, this is developmental cohort from the 70s all the way down to the early 2000s. They took children and they followed them over 30 years, basically looking at their development. They looked at childhood risk factors and adolescent risk factors, and then adult risk factors. And what they found was that development was affected by outside influences, be it in children, in adolescents, and adults. And these patients didn't have any underlying cardiac conditions. What they also showed, and this is sort of similar data, non-congenital patients, 1,000 children who were followed for 30 years, and they controlled for gender and social class. But what they found was that if you have better inhibitory control, a better executive function as a child, then the chances are that you will do better in the future. You'll do better when it comes to decision making. What that means is you'll have better outcomes, you have better quality of life, higher incomes, you'll have better jobs. So why am I showing you this is because clearly there's a tremendous amount of data in non-congenital, and again, non-congenital cohorts. I thought this was very interesting. What this means really is that executive functioning, it starts early, but it is a continuum. It's a malleable process, which means as time goes on, as decades go on, based on the influences that you're coming, or those all of us go through, not just patients, but all of us, then we can make it malleable. We can change those outcomes. And what that means is that if we can control factors like stress and anxiety and sleep deprivations, I'm just putting some factors out there, then the chances are that we might have better outcomes going down the road, many decades down the road. So what this means is that when little people are overwhelmed by big emotions, it's our job to share our calm, not to join their chaos. So we see this, and there's data, as I said, in children with congenital heart disease. But can I flip it around and can I say the same? So that when big people are overwhelmed by little emotions, it's our job to share our calm and not to join their chaos, because this is a continuum. This is something that's happening. I'm going to end here in 3 minutes and just bring you to quality of life. And this is, again, a huge topic. I'm not going to get into the granularity of this. If Philip Moons is listening, then this is Phil to you, is that this is quality of life. This comes down to quality of life. Why is that important? Because what is it? What this means is that this is a broad concept where physical health, psychological health, level of independence, social relationships, personal beliefs, the association of people, patients, or be it a child or an adolescent, adult, how they react to their environment. And why is that important? Because there are many dimensions to quality of life. We talk about the physical, which is our world, patients who have physical, sorry, I apologize, but a medical or surgical conditions, the social aspect, the economic aspect, the psychological aspect. But if I throw in cognition there, is that something in our world of adult congenital heart disease that lends itself to quality of life? And I think it is. And Scott Cohen touched upon this also, saying that, well, if you have neurocognitive deficits when it comes to adults with congenital heart disease, there's lower education attainment, there's more unemployment, there's less relationships or good relationships, marriage, it leads to depression, and there's a worse quality of life outcome. So what does this mean going forward? I'm going to end here in a few minutes, is what is the future when it comes to neurocognition and adult congenital heart disease? As I said, there's only about 35 papers out there, out of which really about 15 of them are clinical studies, small cohorts in adult congenital heart disease. And I'm going to plug in this with just to tell you about Minds ACHD. We're doing a multi-center prospective study. Scott Cohen and Michelle Gervitz are part of this. There are 13 sites, and just to tell you, we're looking at a little over 500 patients with moderate and severely complex. And Toronto, as Candice and Rafa know, are part of this. So there are 13 centers that we're looking at. There's some inclusion, exclusion criteria. We're going to move away from syndromes and underlying genetic cardiomyopathies. There is sophisticated testing that we will be doing. We have a whole neuropsychology core that is at the Medical College of Wisconsin. And as I said when I started this talk, is that the key is neuropsychologists. It's what they bring to the table. And as you look here, these are tests that take time and then need to be assessed. We're going to look at patients coming in at all the different centers. We'll test them for neurocognitive functioning, and then eventually that data will go to the core, and the core will look at it. We've recently launched, and this is a collaboration with ARC. This is a collaboration with ARC and the Pediatric Heart Network that's funded to the NHLBI. And we're also doing a neuroimaging ancillary study. So as I just showed you the data from Australia and New Zealand, they're already a step ahead of us. They had a very sophisticated study, and this is being led by Pittsburgh at Ashok Panagrahi, and Michelle, Scott and myself are going to be involved. So let me end here in the last minute, and just sort of, as I said, it gave you a whirlwind, sort of a bird's eye view. And what does this mean with neurocognition? Is that yes, this is not a perception. This is here to stay. This is a paradigm shift. This is something that we need to start thinking about. There are many risk factors, both congenital and acquired. Wearing my pediatric cardiology hat on, as I said, there are risk factors we need to look at. Wearing my adult cardiology hat on, there are adult acquired risk factors. And as I said, the data for older adult congenital heart patients is just not out there. There are layers of neurocognitive dysfunctioning. It does come down to executive functioning, but within that are granular domains where we turn to our neuropsychologists for guidance and help. And the impact of neurocognitive dysfunction has been shown that it will lead or can have an impact on quality of life. And it may differ from when you do this. So if you're looking at a patient or a child with neurocognitive concerns versus a 18-year-old, someone who's transitioning to a 50-year-old person, I mean that those manifestations may be different. And we certainly need more research, as I've been learning over the last few years, as I said. So Minds ACHD, as I've just talked about. So what does this mean? Is that, well, it's not really a perception anymore. I don't think it ever was a perception, but But for us, the question that comes to my mind is that this is something that we as ACHD clinicians or clinical investigators, certainly not a bench researcher by any means, but can we bring change, or can we do something that will change practice guidelines and improve care for adults with congenital heart disease? And that's something that still needs to be determined. It's certainly something that's out on the horizon. So what does that mean? Does that mean we need early evaluation? We need early intervention? Do we need to modify those risk factors? As I said, those risk factors are different when you're a 5-year-old versus a 10-year-old versus a 30-year-old versus a 60-year-old. So as I said, it's a malleable sort of a process. Yes, there are some fixed processes like congenital heart disease and the effect it has on the brain. So yes, there are some concrete processes that we may not be able to change, but can we bring a change? But I think we can. I think we can. We can certainly do this, but it will need more direction, more research, and more collaboration. So I'm going to just say thanks to the folks that I've been working with. I've learned a lot from these people, from the ARC Network, from Pediatric Heart Network, the NHLBI, and Michelle and Scott, Kristen Burns, Laura as a neuropsychologist that I've learned tremendous amount of data from, Olivia and Lauren, and a lot of other people. But let me stop here. It's right around 8:45, Raf. I'm going to hand this back to you. So thank you,
Ali. Excuse me. Thank you, Ali, for the excellent talk. So a very interesting and challenging topic, I think. So any questions? If you have any questions, you can either type them on the chat, or you can unmute your microphones and ask the questions. Lorna has a question on the chat. Thank you for the great overview. Are you doing any routine in New York? Are you doing in New York any routine screening assessment on your normal clinic patients with your research protocols? Or
yeah, so that's a great question. So we haven't yet, but we will probably start. So the MINDS project is really what's going to help us do it. But the question was outside research. We haven't done that yet, and I'll tell you why. And some of this is what I sort of touched upon a little bit, is that what I've learned over the last few years is that neurocognitive testing can be done in a couple of different ways, but the testing has to be done well. It has to be validated, what those results will mean, and do you have a neuropsychologist who can work with you to then interpret that data as to what that means. And I didn't get into this, but once you have a problem, your next step as a clinician becomes, how will you address that problem? How will you get that person referred to a neuropsychologist, and what will be the next few steps ahead? So we are still working on that, but there are many layers to that question. But the short answer is no, but we are hoping to in the future.
Okay. Any other questions? So that along with your last comment was my comment or questions, that I think that this in my opinion, we as a cardiologist, we try to not to look at things that we do not understand and ignore them. I don't think this is new. If in children, as you said, and you show very good data is there, so it's obvious that it was in children, must be in adults. But so I agree with you. This I think is somebody opened the Pandora boxes, comes to stay. What do you think? How do you think we're going to be able to handle this? Because as soon as you know that there is a problem, we have an obligation to fix it, and it's obvious that I'm of the idea that the adult congenital heart disease unit should have at least a psychologist to help the patients to navigate through the difficulty of living with congenital heart disease. But this is probably more than a psychologist what you're going to need, because this is a neurocognition problem that's with maybe or maybe not, because we don't know, but maybe with the appropriate measures and with the adequate management might change the outcome of the patient. So I know that this is completely a philosophical question, but how do you see this implemented in our daily practice?
So fantastic question, Rafa. A very difficult question on many levels. It's a difficult question. So the first point that you made is absolutely spot on. And I think those of us who are clinicians, primarily clinicians, and take a this is something, as you said, has been on the horizon. That's been there for 20 years. I mean, the data from children with congenital heart disease and neurodevelopment, it's out there. They've been talking about it for 25 years. We haven't, as ACHD physician, or at least I don't think I can speak for myself. I haven't spent that much time thinking about it. So you're right. We tend not to look at things that we don't understand. I agree with you. Now that this thing is on, this is out in the open, how do we handle it? Well, I'll break it operationally into a few things, because for the last 2 years or so, we've been trying to figure out how we're going to do this. You absolutely need a neuropsychologist working with you if you are going to do this. Because this is not something that you and I or other ACHD physicians are going to be able to do in a 30-minute clinic visit. It's just not going to be able, you won't be able to. So the testing itself is complicated, it's time consuming. So you'd absolutely need a neuropsychologist, or you want to call a neurocognitive specialist, working with you if this is something you want to do. That's number one. The second part is what you said, how do you handle it? And what I've learned is that what they find, and as you saw the data, it's tremendous. I mean, this is not 2% of people having it. I mean, this is across the board. You're seeing quite a bit of challenges in many different domains. And what I'm trying to say is that once you identify it, fixing it or trying to fix it is a whole different ballgame. It's a whole different ballgame. And I've learned this the hard way, in the sense that I thought this would be easy, but you really have to get a whole team together who will then work with these patients. Or you have a referral line that will say, we did the testing, this is what we found, this is what a neuropsychologist is saying, treatment's going to be somewhere else. So there are many, many operational arms to this, Rafa, which are, I think, difficult. We haven't been able to, we're getting there at Sinai, but I'm sure other centers have it already. But yeah, it is an operational challenge. This is not easy.
That's what I expect to happen, but I think that we're gonna have to deal with it, because as long as we know, we have an obligation to act on it. So there's another question on the chat, which is from Nauman. As we know, a good number of patients with congenital heart disease have intellectual dysfunction, like 20q11 or Down syndromes. Are all these patients excluded from those data that you were shown, or the Down syndrome and 20q11 were included in the papers that you have discussed?
So good question. So a lot of the data that I showed you, what's really interesting about the data when you look back is that when you get granular and read through the data, they actually don't look at genetic syndromic patients in a lot of and in the 30 studies or the 35 studies that are out there for adult congenital patients, they have sort of moved. What the data that's out there is just ACHD patients who are non-syndromic, purely just congenital heart disease patients. But again, these are very small studies. So I think, just so I understand, the question is, like, is there data for this in syndromic patients? Not that I can see. And correct me if I'm wrong, Rafa, is that the question? I'm not, the data hasn't been.
I think that's the question. I think that's true. The syndromic. So my understanding with the papers that I read about the topic is that what they wanted to show is that patients with no syndromic syndromes had neurocognitive problems, because you assume that everyone with, well, not everyone, but 20q11 patients and Down syndrome will have it them no matter what, regardless of the congenital heart disease. And in patients with no other reason to have a neurocognitive disorder, that's the only reason to have as a congenital heart disease. The papers, these kind of papers, try to show that your neurocognitive problem is linked to your congenital heart disease. Another question. Sorry.
Thank you, Dr. Rafa, and thank you, Dr. Ali, for the very tremendous talk. So the reason to put this question is that, because, as you know, that all these neuropsychiatric involvement in these syndromic patients, they tend to change the outcome of those studies. Like, if we are analyzing those data in the presence of those patients who were not excluded from the beginning, they can change the whole balance of the outcome. So that was the question: that is it an exclusively for those ACHD patients that does not have any other reason to explain the neuropsychiatric dysfunction or neurointellectual dysfunction? That was the main point.
That's correct. That's correct. So thank you so much for the question. So that is correct. So the reason why, I mean, I can speak for the prospective mind study that we're doing, which is, as I said, across 13 centers. We have excluded anybody with any underlying syndrome or genetic condition or genetic cardiomyopathy, primarily for what you said, is that we want to keep the data cohort, the data set that we get clean, so that there are no confounders that might be coming from i.e. a genetic syndrome. Or so you're right. I think your question actually is your answer. I think that's exactly what it is. So yeah, so there's I think there's I can see some. Oh, there is a comment there too. One of them is neuroplasticity affected in your patient? Oh boy, that's a tough question. I don't know yet. I don't know the answer to that, because what we know, what I can answer is that what we've seen is that there is changes in the white matter. The white matter of the brain, there are changes. We can see that. And I didn't show you this data, but I can, and maybe in the future, is that in children, there have been some brain imaging that has shown that white matter changes are evident. That hasn't manifested itself in adult patients just yet, so we don't know how the brain will change as time goes on. But as I said, we are doing a neuroimaging study, and that will take us a couple of years to get the data out. So I don't know the answer to that at this point in time.
So I need to take over from Dr. for Erwin's computer, because my computer went down. So there is another question that said, is neuroplasticity affected in your patients?
Yeah, I just took that, Raf. I was saying,
I'm sorry, because I was in the middle of sorry.
That's okay. I mean, the short answer to that is
what Lorna is asking here is it's going to be a while before we have resources to fully assess a lot of patients. And are there more simple? Do you think there are more simple measures that we can share with all of our patients to protect the neurocognitive health and neurocognitive function now that until we get to the point that we have more resources to address this?
Yeah, so that's actually that's a very practical question. It's actually a fantastic practical question, and just so other folks who are listening, and really the question is, what I just explained is sophisticated, validated tests that take time, that need ancillary support. So yes, so can we do something simple? So the short answer to that is that there are some questionnaires that are out there that we can screen patients for neurocognition, just screening. So we're not going to get into the granularity, but just screen patients. And if you sort of do some screening, and you find that this patient has a neurocognitive problem, then you take that patient and say, well, we're going to refer them to a neuropsychologist or down the road. So you just screen them. So the short answer is, are there some questionnaires out there? Yes. Now the caveat to this, and I'll explain this again, is that these questionnaires that are out there, we have to be very careful if they are research-based and they're validated. There are questionnaires out there that are non-validated. What that means is that you could screen them, but the results, you don't quite know what the results mean, because they're non-validated questionnaires. So you have to be careful. So the short answer, Lorna, is that there are some tools out there, but we have to be careful. But as I said, I mean, the issue that I'm seeing on an operational, practical standpoint is that this is something we need to work on, and how we as clinicians are going to address this when problems are identified. I don't have great answers for you there, because I don't think every center will be able to do it just yet. Big centers might.
Mm-hmm. So I think it's a fascinating topic, and one area that I think it is important, that's going to be at least have an impact and might be helpful, is in patients during the transition period. Mm-hmm. Because I think it's one of the most challenging periods for these patients, and where, as you said, you mentioned something that I always mention in my transition talks, that the brain develops until you are 25. Yep. And that's why the transition is recommended to keep until 25. Yep. But I think, as you said, this topic is, we know now, we opened the Pandora box,
Right.
And I think came to stay, and we're gonna have to up our game, and we're gonna have to learn about it.
Absolutely, Rafa. Absolutely. I think there's a lot more to come. In the next, I think the next 10 years, we'll learn a lot more.
Which is very, very exciting. And I'm probably we're gonna have to rethink how we're gonna organize the congenital units, because as soon as we know that this happened, these patients have this problem, we're gonna have the obligation to help them throughout.
Right, absolutely. I think, as you said, I mean, I think we're finishing up. It's 9 o'clock. I just want to thank everybody who listened, and Rafa, to you and Erwin for allowing me to speak. But I agree. I think this will take time. But I do think that this is collaborative with not just us, but with, I keep driving this home, is the neuropsychologists. We will learn a tremendous amount from them. So a lot of collaboration.
Another group to integrate in the family of other congenital heart disease, which we depend of many people. So part of the multidisciplinary team group that look after these patients.
Right. No, I agree. It's as I've always told people, it's ACHD has many arms to this. So as I said, we've just added another arm.
I agree. Okay, so if there are no other questions, we're gonna close down here. Thank you, Ali, for the excellent talk. Thank you for joining us today, and thank you for the great discussion. So I will say, and I will say also goodbye. And for the attendees, please don't forget to fill the survey, which is for you can get CMEs with these talks. And see you next week, and good morning, good afternoon, or good night, wherever you are in the world.
Thank you, everybody.
Okay.
Have a good day, guys. Thank you so much. Bye-bye.
Bye-bye.